Focused assessment with sonography and trauma, also known as the FAST exam. This is for the MS3 surgery clerkship. We're going to discuss the basics of the FAST exam and go over a few cases. This diagram shows us proper positioning of the probe for the FAST exam. We want to first assess the lungs. Next, we're going to look at the heart. And then we're going to look at the right and left upper quadrants, as well as the right and left pericolic gutters. And then we're going to image the pelvis. Now you can use either the curvilinear probe or the phased array probe, whichever is available. So as with any focused bedside ultrasound, we're asking a few basic questions. So in the FAST exam, we're asking whether or not there's evidence of a pneumothorax, whether or not we see a pericardial effusion, and if cardiac activity is present, if there's any evidence of hemoperitoneum, and if we see any signs of a hemothorax. So the FAST exam, like all tests, has its limitations. Now I know you never think you would hear me say that ultrasound has limitations, but it does. So the things that the FAST doesn't look at very well are retroperitoneal injuries, hollow viscous injuries such as injury to bowel. It also does not quantify injury severity or location, so you'll know that you have hemoperitoneum, but you may not know if it's from a liver lac or a spleen lac or some other intra-abdominal injury. So you might want to know who needs a FAST. Well, I would say any critically ill trauma patient absolutely requires a FAST. This way, you can determine which life-saving interventions need to be carried out immediately. So if they have a pneumothorax or a hemothorax, they need an immediate chest tube. Or if they have a pericardial effusion, they need a thoracotomy. Or if they have hemoperitoneum, they need to go directly to the OR. I would also say that all stable trauma patients need a FAST. This way you can detect any early life-threatening injuries, and sometimes a FAST exam may be the only imaging besides maybe a chest x-ray that would be required in this trauma patient if they were stable. So when doing the FAST, I like to start with airway and breathing, so I tend to look at the lungs first. Now if you look at the ultrasound image on the left, we're asking ourselves one basic question: is lung slide present? On this ultrasound image on the left, you can see the bright white pleura, and you can see it sliding nicely. Sometimes this is called ants marching. Now the image on the right, you don't see any lung slide present, and this is indicative of a pneumothorax. Now here are just a few other examples. The image on the left, you can see the lung slide at the very top of the image, and on the right, this is actually called a lung point. You can see the interface between the pneumothorax and the normal lung. Now a FAST exam does not tell you how big the pneumothorax is, so as with every other test that you do, you want to take the clinical scenario into account. So if the patient were to be hypoxic and have a pneumothorax, then they would need a chest tube. However, if they have normal SATs and have no complaints of any respiratory distress, you could do further testing before deciding whether or not they actually need a chest tube. So going along with our ABCs, we'll take a look at the heart. So we're asking ourselves, is there cardiac activity? Well, obviously in this image on the right, you can see the heart, it's beating nicely. Now we're going to look for pericardial effusion to tell whether or not there's hemopericardium. Now in this image, you can see a nice bright white outline of the pericardium around the heart, and there's no evidence of a pericardial effusion. Now here are two other examples. The one on the left is normal, while the one on the right shows a pericardial effusion, so hemopericardium with evidence of cardiac tamponade. This patient would require immediate pericardiocentesis and most likely a thoracotomy, as well as going to the OR. So next we're going to assess for hemoperitoneum. We're going to look in both the right and left upper quadrants. Now when doing this, we want to make sure to sweep all the way through so that we see the interface of the diaphragm with both the liver and the spleen, as well as the interface between the kidney and the spleen and or the liver. Then we're going to sweep down and look at the pericolic gutters on both sides. And then we're also going to take a look at the pelvis by sweeping all the way through the bladder. Now both of these images are normal. The one on the left is of the bladder, and as you can see, there's no evidence of any free fluid. And the same on the right. This is the right upper quadrant, and there's no evidence of any free fluid or hemoperitoneum in this image either. Now here are two examples of a positive FAST. These are both of the right upper quadrant. The one on the left shows free fluid in Morrison's pouch, and the one on the right shows free fluid just at the tip of the liver, which can be easily missed if you don't do a full sweep through the right upper quadrant. Here are some subtle examples of a positive FAST. This is hemoperitoneum, and you can see it just there behind the bladder. Now, one other question we can answer with the FAST exam is whether or not there's a hemothorax. As you can see in this image on the right, this is of the left upper quadrant, and you can see the presence of a hemothorax here just above the diaphragm. This patient would need an immediate chest tube. So let's get started with the first case. This is your first day of trauma, and your pager goes off, and it says a P1 trauma page. You're told that the patient was ejected from a motor vehicle accident. Their GCS is about 10. Their vitals, their heart rate's 115, blood pressure 90/65, and they're satting 85% on a non-rebreather. Now the trauma bay is very chaotic. It's loud. You think somebody says that they have decreased breath sounds on the right. There's obvious trauma to the abdomen and head. So you decide that you're going to do a quick FAST to determine which life-saving intervention you need to do next. So these are the initial images that you obtain from your FAST exam. As you can see on the left, you have your right and left lung. And on the right, you can see your subxiphoid image of the heart. Now, both lung images are normal, and you can see positive slide. And then on the right, you can see good cardiac activity and no evidence of hemopericardium. So now you move down to look at the abdomen. You're going to look at your right, left quadrants along with your bladder/pelvis. So in these images, the one on the left is of the right upper quadrant, and you can see hemoperitoneum just there between the liver and the kidney. So this patient has a positive FAST for hemoperitoneum in the right upper quadrant. This is an unstable trauma patient and would require immediately going to the OR. So case 2, this is a 6-year-old male brought into the emergency department after a bike accident. He kind of fell into the handlebars. He was wearing his helmet. He feels a little sick to his stomach but really has no complaints. This occurred just prior to arrival. His vitals are normal. He has some mild abdominal tenderness, but there's no real evidence of trauma. So you decide to go ahead and do a FAST exam. Now, as you can see on the left, the lung ultrasound is normal with good slide. The subxiphoid window of the heart is normal without any evidence of hemopericardium. And the representative image on the right of the right upper quadrant is negative for any hemoperitoneum. So this is a negative FAST exam. So a negative FAST exam, the patient's tolerating PO, he's looking great. We decided that we're going to observe him in the emergency department for a few hours prior to discharge. Now you're getting ready to discharge him home when he starts having a little bit of vomiting and complains of some abdominal pain. His vitals are completely normal. So you decide you're going to go ahead and repeat your FAST, and this is the image that you see here on your left. So you can see that there's free fluid in Morrison's pouch. So this patient now has a positive FAST exam. So at this time you go ahead and decide to get a CT scan, which shows a small liver laceration. He's admitted to the hospital, observed. He doesn't require any surgical repair. He's able to be discharged a few days later. In this case, we wanted to try to avoid radiation with the CT scan initially. However, when the patient developed abdominal pain and vomiting, we had a repeat FAST, which was positive, and went on to do a CT scan. In this incidence, the liver laceration was detected, Serial fast exams can be a useful way to monitor patients who have low mechanisms of injury and whom you don't expect any major injury. This is particularly useful in children and pregnant patients in whom you want to limit the exposure of radiation from CT scans. So the FAST exam is a quick, rapid assessment at the bedside of the trauma patient, which allows you to make immediate life-saving decisions. You can look for a pneumothorax, a hemothorax, hemopericardium, and hemoperitoneum. Now, like with any test, there are limitations. The FAST exam is not good at detecting retroperitoneal injuries or bowel injury. Now, all trauma patients, whether stable or unstable, should receive a FAST exam. This way we can detect life-threatening injuries earlier and provide life-saving intervention faster. Thank you.